Welcome to Roadmap to Residency. Hello everyone, I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. This video is on about pancreatic cancer. Which of the following types of pancreatic carcinoma is most likely to be found in this patient? A 65-year-old man presents to the clinic with a 3-month history of jaundice, significant weight loss, and persistent upper abdominal pain. He has experienced a noticeable decrease in appetite. Physical examination reveals icteric sclera, a palpable gallbladder, and right upper quadrant tenderness. Lab tests show elevated serum levels of bilirubin and alkaline phosphatase. Abdominal ultrasound demonstrates a mass in the head of the pancreas with dilation of the common bile duct. Which of the following types of pancreatic carcinoma is most likely to be found in this patient? Pancreatic adenocarcinoma, intraductal papillary mucinous neoplasm, pancreatic neuroendocrine tumor, solid pseudopapillary tumor, and a cystic pancreatic carcinoma. So the most likely type of pancreatic carcinoma found in this patient is pancreatic adenocarcinoma. The clinical presentation with jaundice, significant weight loss, upper abdominal pain, decreased appetite, and icteric sclera, all of which are suggestive of pancreatic carcinoma. Palpable gallbladder or Corbusier sign is a notable physical finding seen in patients with pancreatic adenocarcinoma. It is typically associated with cancer-related obstruction of the common bile duct, leading to biliary dilatation. Lab findings. Elevated serum levels of bilirubin and alkaline phosphatase are indicative of obstructive jaundice, a common consequence of pancreatic adenocarcinoma when it involves the head of the pancreas and obstructs the common bile duct. Imaging abdominal ultrasound reveals a mass in the head of the pancreas, which is a common location for pancreatic adenocarcinoma. Dilation of the common bile duct is also a common finding in cases of obstructive jaundice due to tumor compression. Now let's talk about pancreatic carcinoma. Everything that you need to know to answer any question that is being asked in the topic pancreatic carcinoma. So pancreatic cancer is an adenocarcinoma that is derived from the exocrine ductal epithelium. Epidemiology, second most common GI malignancy after colorectal carcinoma, 2 times more common in men than women. The causes include smoking, which also includes the smokeless tobacco, chronic pancreatitis, hereditary pancreatitis, diabetes mellitus, obesity, cirrhosis. Pathogenesis. So there is high association with the KRAS gene mutation, and it is a mutation of the suppressor genes. The location of pancreatic cancer is mostly in the pancreatic head and then in the body tail and diffusely. It often blocks the common bile duct, causing obstructive jaundice, and grossly the cancers are infiltrative and firm. Macroscopically, they can be well, moderately, or poorly differentiated. So here you can see that most of the carcinomas occur in the head of the pancreas, and this also impinges the common bile duct, causing the dilation of the common bile duct, and rest of them occur in the other parts of the pancreas, which are not commonly asked in the USMLE. You can see the infiltrating adenocarcinoma of the pancreas and irregular form white mass is present in the tail of the pancreas, and tongues extend out to encase the arteries and towards the spleen. Adenocarcinoma of the pancreas. So number A is the well differentiated. We already have seen in the theory part from these, it is classified histologically from well to poorly differentiated. So this one is the well differentiated adenocarcinoma. This is the moderately differentiated adenocarcinoma, and this is the poorly differentiated adenocarcinoma. Here you can see the exocrine glands, and here you can see there is more of the fibrosis occurring, and here you can see the haphazard arrangement that is not, anything is not clearly explainable in this image. Clinical findings include epigastric pain with weight loss, signs of CBD obstruction or common bile duct obstruction leading to jaundice, light-colored stool, and palpable gallbladder. There is superficial migratory thrombophlebitis, which we'll discuss in another chapter. Metastasis to the left clavicular node or Virchow node, which is non-specific because it also occurs in stomach cancer. The peri-umbilical metastasis, also called as the Sister Mary Joseph sign, also occurs in the stomach cancer. The lab findings, there is increase in the CA19-9, which is the gold standard tumor marker. So you need to remember this information. CT is used for imaging as well as for guiding percutaneous biopsy of the pancreatic mass to secure the diagnosis. The overall survival rate is only 3 to 5%, which is within a median survival time of only 6 to 10 months if metastasis is not present, and 3 to 5 months if metastasis is present. So we can see the carcinoma of the head of the pancreas in this figure, the signs and symptoms resulting from the 6 major pathophysiologic or pathological changes. So the signs and symptoms, the general effects of the malignant disease, which are seen in each and every cancer, is cachexia and anorexia. If there is obstruction of the common bile duct, then that will lead to obstructive jaundice. If there is a nerve compression, then that will lead to the pain. There is consistent dull aching pain or epigastric pain. Then also, if there is obstruction of the pancreatic duct, then that will lead to the decreased excretion of the pancreatic enzymes, and that will subsequently lead to malabsorption and diarrhea. If there is duodenal obstruction, then that will ultimately lead to the nausea and vomiting. And if there is metastasis, then that will lead to hepatomegaly and pain. So liver is the most common site of metastasis. You can also see the carcinoma of the head of the pancreas. The contrast enhanced computed tomography image shows a large mass M here. This is the carcinoma head of the pancreas. Now let's talk about the Whipple's procedure. So the Whipple's procedure is an in-block resection of the pancreatic head and neck, which is the distal pancreas, remains to prevent the diabetes mellitus. So whenever you have a pancreatic cancer in the head of the pancreas, then what we do is that we remove the head and neck of the pancreas, and the distal part, the tail is left there because we need a pancreas to make insulin so that the patient is not vulnerable to diabetes mellitus. In some cases, there is resection of the antrum with vagotomy. So the bile duct is attached to the small intestine directly, and the stomach is attached directly to the small intestine, and also the remaining part of the pancreas is attached to the small intestine. So here we can see this is the gross image. Okay, also this is the after OT image. So distal stomach, duodenum, and head of the pancreas, proximal jejunum, and gallbladder. These all structures are removed in case of Whipple's procedure. So what we do is that we remove the distal stomach, plus we also remove the head of the pancreas and the gallbladder and the proximal jejunum, and then we anastomose everything just like what is shown in this figure. So let's review the facade of the pancreatic adenocarcinoma before we end this video. So pancreatic adenocarcinoma, which is a very aggressive tumor arising from the pancreatic ducts, disorganized gallbladder structure with cellular infiltration is shown here in figure A, is often metastatic as presentation with average survival of nearly 1 year after the diagnosis. Tumors more common in pancreatic head that is lead to obstructive jaundice and associated with CA19-9 tumor marker. These factors include tobacco smoking, chronic pancreatitis, diabetes, and age more than 50 years. It often presents with abdominal pain radiating to the back. There is weight loss due to malabsorption and anorexia. There is migratory thrombophlebitis, which leads to the redness and tenderness and palpation of extremities, Peutz-Jeghers Syndrome, and obstructive jaundice with palpable non-tender gallbladder or Courvoisier's sign. I think we have covered all of this in our lecture. So thank you for watching. That was it about pancreatic carcinoma.